Ken Culver, and I'm the Director of Research for ALK Positive, which is a form of lung cancer, mostly in young people who are non-smokers. So we're very interested in any of these new technologies, these new data that could impact the care of our patients and our drive to get a cure. Yesterday, there were really nice outputs for the ROS1 lung cancer type in the ARROW study from Nuvalent, and that's really exciting. Even though it's not ALK specific, it shows the investment and the ability to make great new drugs for patients with oncogenic driver type lung cancers. And of course, Nuvalent has a very nice drug called neladalkib, which is now moving into the frontline research space. So we're grateful to Nuvalent and all the great work they're doing. In addition, yesterday, we're reminded that genetic testing for these oncogenic drivers is still only around 60 or 70%. So that means if you can live for 10 years with ALK positive lung cancer, some people are not getting the opportunity, and that's a tragedy. And the meeting like this really reminds us how we have really great drugs and treatments, but patients have to be tested and have access for them to do any good. The next thing that was really interesting yesterday was the presentation of the ivonescimab, the bispecific antibody that binds PD-1 and binds VEGF. And while there are really good signals with that drug, it really hasn't proven itself yet. Although I'm understanding now that additional data is coming out that says there may be a survival benefit. The thing about that matters the most is they've treated thousands of patients with that bispecific antibody, but not one ALK positive lung cancer patient. And we know our patients express VEGF. We know our patients are PD-L1 positive in most cases. Our patient community deserves to be a part of those trials sooner. And so whether it's the antibody ivonescimab or whether it's BioNTech or the others in development, we really want to tell companies, please include a cohort of ALK positive lung cancer patients, because who knows, they may respond way better than other subtypes, and our patients deserve to have that part of their research opportunities. The FLAURA2 data that came out yesterday was with the EGFR patients, chemotherapy plus osimertinib, reinforces the idea that there are these high-risk populations that we don't know who they are, but adding a second agent in the first line improves the benefit. We know with the very best data with lorlatinib in the CROWN trial that the median PFS has not been reached after 5 years, but 30% of patients have progressed within the first 2 years. And we don't know if we added chemotherapy up front, like they do in FLAURA2, would that change the course and change the long-term outcome for at least 30% of patients. So I think these raise important questions that I'm hoping the research community can answer that will help our ALK patients live longer and better lives.